greatest problem of the NHS in England is its size, and the greatest promise of the NHS in England is its size, because in the scale of what you try to do in this nation stands the possibility of immense amount of learning. To improve scientifically, you need two things. Aim, intention, you have to decide to do it, and then you have to have a way to do it, as simple as that sounds. In 2001, in the US, a chartering document appeared from our National Academy of Science, the Institute of Medicine. It said we're going to have care that is safe, that isn't harming people, aim one. Aim two was it will align with the best known science. If we know how to cure leukemia, every single leukemic child in America will get the benefit of that knowledge. It will be patient-centered, and there's a continuing, evolving sense of what that really means. The fourth was timeliness, that delay is generally, unless it's instrumental, it's a defect. Efficiency appears on the list. It's the reduction of wasted effort. And then equity. In America, that's racial equity. The biggest predictor of your survival in my country is the color of your skin still. This is a very important set of framings, and it began to guide effort in America. But then things changed. It changed due to Whittington and Nolan's perception of the triple aim. They added two other goals. The second goal was don't get sick in the first place. And the epidemiology here is very clear. If we assign 100 points of variation to your health, statistically, 50 of the points are in your genes. Someday we'll probably manipulate that. We can't do much about that today. But 50 points of your health variation remain up for grabs. 10 of those 50 points are assignable to healthcare. 10. 40 are assignable not to healthcare but to other controllable things like nutrition, exercise, violence in society, poverty, the quality of the air. Controllable but not in the healthcare system. And Whittington said, time out, we can't do that anymore. If we really are going to seek health, which within my country with nearly $3 billion of investment, we've got to begin to understand that the pursuit of health does not lie solely within the then existing healthcare system. So they added the second aim, population health. The third aim, it's stewardship of collective limited resource. It's a challenging idea. I would say the core of the notion is that healthcare, as important and as good as it is not entitled to its income. There are opportunity costs. I saw these foursquare running for governor. I saw in a state budget the constant, and I used the word, and I will write this and say it again, the constant confiscation of social resources, public and private resources, by healthcare. If we, stewards of care, don't take responsibility for the management of our share of a common pool resource, others lose. It looks like a win, but it's a loss from the community's point of view. I've begun to regard that concept as just as important ethically as the idea we're not going to harm patients in our hands. And so the conservation of healthcare, in the case Whittington and Nolan suggested, it was per capita cost, was their framing, became the third aim. Take the 5-year forward view. So I've read this a number of times. I think it's terrific. I will say that I don't yet see a vision articulated of the evolution of a system of seeking health and healthcare in any nation quite at the level of the 5-year forward view. When I read the 5-year forward view, I see the triple aim. You're really intending to work on the experience of care, but even more exciting than that to me is what you are saying in the 5-year forward view about population health. The language is uncompromising, radical upgrade in prevention of public health, and then some very interesting foci in upstream work on diabetes, prevention in general. And I think one of the most thrilling ideas, really pertinent ideas, in the 5-year forward view is do it first within the NHS to its own employees. Terrific. And then there's the per capita cost piece. Now this one you've minced your words a bit about. Of the 30 billion gap, I think you're looking for 8 billion revenue. Something like that. So you haven't quite taken the whole pill here because you'd like some more, and I credit you that. Your costs are so much lower than my country's, I believe you. That leads us to an element of maturity in stewardship of the triple aim, and that has to do with the sense of waste, the sense of excess. You would only really embrace the triple aim if you actually believed that within the healthcare delivery system lies a non-value-added activity. Otherwise, you're into rationing. I'm putting to you that even the 22 billion goal, I think, is achievable within your system without harming a hair in anyone's head. 34% of healthcare production in my country is pure waste, non-value-added. That's a lot of money in a $3 trillion system. If we could get 1/3 of that out of our system, it would solve every problem American healthcare has with cost and confiscation. It is by no means illogical or unscientific to begin to say that better care, better health, and lower cost can be simultaneously achieved. The first change is to move to AAA and embrace it. The second change is to understand a theory of action that you actually believe will work. And here we have a problem, your country and mine, and not just in healthcare, which is a benighted, incorrect, scientifically incorrect theory of action. When the team loses, you fire the coach. It's the concept that somehow in the population of distributed effort, there's a few people, a few places, some stuff going on that you've got to find and catch and get rid of. I called it the bad apples problem in a paper in 1989, and it remains the basic approach in the public discourse, in the media. It's part of improvement, and in a publicly accountable system, you've got to do something about it. You have to have inspection-oriented work just to give everyone a sense of safety, but it is not improvement. Not improvement at scale. It has very little to do with the way most of us improve most of our lives most of the time, and it frankly has almost nothing to do with the proper pursuit of the 5-year view. Until and unless at scale a new ethos can emerge in any system, and I would mean a system of education or a marriage, until a new regime emerges which is differently oriented, improvement will be elusive. Security can be found. You won't have mid-Staffordshires again, but you won't have improvement. Improvement looks like this. It's the continual design and redesign of production. And it's the only route to the AAA. The core idea is that every system is perfectly designed to achieve the results it gets. NHS England today, perfectly designed to have whatever levels of cost characterize it, whatever levels of mortality, of injuries to patients, of waiting times, of satisfaction, joy in the workforce. All of the products are products of the way it's designed today. If you think you can inspect your way to better, forget it. You can't. How do you get change in systems when they're complex and interactive? In a hospital, in a clinic, in a community, it's team sport from the start. And so the question is, what kind of regime of action allows the new design to emerge with a new capability? I think you leaders, you have to kind of have three things in mind at once and all matter. I call them technique, culture, and strategy. And I'll be very quick about this. The technical method is learning. It's learning. It's the core activities in which humans, together or separately, engage in order to be smarter tomorrow than they are today. Among the new methods, systems, the vanguards, you can do this. Understand that the same metrics, the same approach to knowledge gaining that you currently use to disadvantage for selection and reward and punishment and culling, it's the same information, but now feeding into a different cultural milieu, one of learning. And so it pulls the teeth of measurement. Measurement loses its fangs and gains productive traction in a learning process. We'll know NHS England is making progress when people can't wait for the next report on performance. The technique will only thrive in certain cultures, and that culture will emerge only when the leaders get focused on the culture of learning. I thank you very much for the time. Sorry for being over time, but I not only wish you well, I want to be with you on this journey. It's a wonderful expedition, and I know you'll succeed.